cervix, we can see the ureter and the uterine artery over the side, running the transverse, lateral, McEnroe's ligament, the retinacular, the meritinacular, uteri, sustentinum, of body. These are supported and it's supposed to be triangular shape, but it's really highlighted where the ureter can be damaged there. We have a fold, a peritoneum, uterosacral fold more, but more important, we have a sacral uterine ligament running back. So you see where the lateral ligaments keep the cervix in the midline, yes? The uterosacral ligament will tend to want to pull it backwards. And by pulling it backwards, it wants to tilt it forward, so it becomes anteverted the uterus, yes? And then this next. But you need something to counter that pull off the...
Round a little bit?
The backward pull off the...
Oh no. Uterus.
Of the uterosacral ligament. Right, Marlon? So this is the uterosacral ligament. The pictures of it, yes? Now, here we have the cardinal ligament coming in. But more importantly now, not necessarily more important than the others, but this is what will counteract the pull of the uterosacral, the posterior pull of the uterosacral ligament. Yes? It's the pubocervicalis fascial ligament. The pubocervicalis is coming from the back of the pubis to the cervix. The pubocervicalis. The corresponding things in the middle are the puboprostatic ligaments. Where sometimes when we are speaking and we're not too sure what it is, if we say puboprostatic, then you will know that we're referring to the pubobicital ligament in the female. I mean the pubocervicalis ligament in the female, okay? Now the pubocervicalis has two portions. I showed in the last diagram that the male puboprostatic ligament is in the form of two parts. A more medial puboprostatic ligament and a more lateral placed puboprostatic ligament, right? Now in the female, the arrangement is a little bit different. More anteriorly, it has a distal, a vertical portion. And it's saying here it's supposed the urethra and the ureterobicycle junction. And against which the urethra can be compressed so that urine doesn't escape you when you cough and laugh, right? And then the other part is the horizontal part of the pubocervical ligament. So the pubocervical ligament will tend to oppose it, pull, the natural pull off the uterosacral ligament and keep the cervix in its position. The area of the purple representing the pubocervical ligament. The green represents the uterosacral, and the what's that off purple representing the lateral McEnroe's ligament. And we have the tips of the round ligament. So all of these structures collectively will serve to maintain the uterus and the vagina in their normal anatomical positions. At the time of hysterectomy, the whole uterus from the body and cervix are removed. Yes? One of the consequences of that is that goes there and that goes. You with me? When you're removing the cervix and the rest of the uterus, you have to divide the adjacent part of the uterosacral and the pubocervical ligament, and needless to say, the McEnroe's ligament there. But the first two, the uterosacral and the pubocervical ligaments, are what are tend to be holding the cervix in this position. And by doing that, they tend to suspend the vagina, keep it up, You follow me? And in real life, this is the one of the consequences that can happen to the lady following a hysterectomy. You with me? Is that they will end up getting a vaginal prolapse because that support at the top of the vagina goes. Okay? Appreciate that. And one of the things they do, non-surgical, the gynecologists do, to help prevent descent of the vagina and the uterus. Sometimes when the degree of prolapse is not too great, or the patient refuses surgery or contraindication to surgery, they put a big plastic ring, like a vessel ring, inside the vagina, and it abuts against the anterior vaginal wall. With me? You can do that? It abuts against the anterior vaginal wall anteriorly, and the other against the posterior wall of the vagina. And this helps to keep the upper vagina and cervix from prolapsing downwards. These are the mechanical therapy for prolapse and the baby. Now I mentioned that pudendal nerve here, which forms an important part of the supply of the levator A, which is an important support for the vagina. And one of the things we're not seeing too frequently, and I don't think it'll happen with girls, one of the problems is with multiple pregnancies and multiple and difficult labors. Yeah, I've told you that per vagina needs corrective weekend palpitations fine. Remember we said that? Yeah.
You said
well, you should be aware. And the pudendal nerve and the vessels are running there, and you should know the relationship of the spine. Sometimes we said we give anesthesia to the pudendal nerve. Some of the ladies, the delivery is so difficult, the mother is tired of pushing, and they put a forceps or a vacuum suction in the baby head, and just to push and pull the baby out. But when you have like the forceps inside the vagina around the baby head, you can imagine that that is uncomfortable. They have to give the pudendal block. You with me? Anyway, that is just a divert. With the multiple pregnancies and difficult multiple labors, one of the problems is that the pudendal nerve is compressed repetitively. And one of the significance of that is that the pudendal nerve undergoes some degeneration. Okay? And when that degeneration occurs, then you see where the pelvic floor, the levator ani, through its pudendal branch, the nerve will go and the pelvis will start to sag. This is just from above showing you the ligaments. Posteriorly uterosacral, laterally the acanthrons, pubocervical ligaments, and at the top, the round ligaments coming around. Now I'm not really finished telling you